Alright, Session 2, Part 2, Orthotic Verbiage. I think it's really important for you guys to understand the language in which questions are being asked. Today you had that oral quiz that told you to express your orthotic goals, and many of you listed things that weren't necessarily not true, but they weren't an orthotic goal per se, or what you're trying to achieve. So yeah, I think it's important real quick to review the differences in some of the vernacular so that you can provide the best and most appropriate answer. Okay, so say if you were asked about UCBLs today, and the question was, what are two orthotic goals you had? You wouldn't want to just say hind foot. Well, I don't know. I can't remember what you said. But anyway, let's just go through overall just orthotic goals in general. So a goal is something that you want to achieve with your orthotic intervention. And there's maybe 6 or 7 of these that are appropriate for any orthosis that you provide. Any one of these goals are appropriate or can be an appropriate reason for having this orthotic intervention. Right, so the first one, these are in no particular order, you guys. Each of these are specific towards a certain pathology. So one is control motion, and this is controlling it in the sagittal, coronal plane, in multiple planes, in just the transverse, in whatever plane you need to control or resist that motion. Alright, the next is correct deformity. So perhaps an orthotic goal could be correct a deformation of whatever. Okay, it would be more specific or more geared toward a pathology. So we have control motion, correct deformity, and then compensate for weakness. So these are our 3 C's. So we have 3 C's and 3 P's coming up in our orthotic goals. I'm not really big on mnemonics all the time or trying to remember things certain ways, but for me, I broke it down into 3 C's, 3 P's, and then there's 2 more after that. So compensate for weakness, this could be weakness in, we could have ligament laxity, we could have muscles that are damaged from a peripheral nerve injury that causes the muscle to become weakened. We could have absence of a particular muscle from birth that could be impairing certain motions. So anyway, compensate for whatever weakness of the ligament, joint, tendon, etc. And then here come our P's. So prevent further progression of the deformity. I believe that Ms. Hill does not like the word prevent, and I believe that Ms. Parker likes the word prevent. Personally, for me, I believe that one of our goals professionally as an orthotist or prosthetist is to prevent progression of the deformities. We are not promising that we can prevent it, but our goal is to prevent this deformity from getting worse. If we are successful in our orthotic treatment, we can see that occurring in preventing the progression of the deformity. So perhaps in scoliosis management, we want to prevent further progression of the spine from becoming worse or having increases in the curvature. We might not be able to completely correct it, but we want to prevent it from happening more. So we are capable of preventing progression of a deformity. It's not always necessarily going to be possible, but we can at least try to prevent it. Additionally, we want to protect the limb or the joint, and then we want to reduce pain. Again, we never promise that pain will be reduced, but we definitely can, or we can't promise that pain will go away, right? But we can absolutely help reducing painful symptoms that a patient might have. All right, 2 more are increase stability of a joint and accommodate a rigid deformity. So in any orthosis for a rigid deformity, you've been taught that we can accommodate that, and we want to pretty much fill in where their musculoskeletal regions have malformations that don't allow for correction. So say someone had a triple arthrodesis, so they have no motion in their ankle, and their ankle has, or their foot has developed a plantar flexion contracture, and it is just 100% stuck. It's not going anywhere. It's fused. It's just done. What we want to do is accommodate for how the foot is. However, if we have a flexible deformity, we want to try to correct it or reposition it into a more stable position. Okay, hopefully that makes a little bit more sense. Now, these are goals for any orthosis, but when a question is asked, what are some orthotic goals for UCBL, these would be the correct answers. Okay, so these are what our goals are. You could clarify and expand on what exactly you want for that particular orthosis, though. All right, so what's an example of that? So you could say, with the UCBL, one goal of mine is to control motion primarily in the frontal plane by limiting eversion and inversion. Right. So you stated that a goal is to control motion, and then you listed almost not a pathology, but you're listing how you would control that motion or what motion you want to be controlled. Okay. Or you could say, because my patient has osteoarthritis of the midfoot, a goal of mine would be to minimize pain if possible through the use of a UCBL. Right? So those are going to be our orthotic goals. So let's talk about some indications. It jumped to number 2. All right. Posterior tibial tendon dysfunction, stage 2 or 3. You'll learn the stagings of posterior PTTD, but essentially, your posterior tibialis tendon inserts on your navicular, and frequently people that have posterior tibial tendon dysfunction have a problem with the the um, with the tendon. So it can oftentimes be too stretched out because of someone putting a lot of pressure on the medial longitudinal arch. So it's that arch is almost collapsing, and you want to help support that arch and support the navicular from dropping because the posterior tibial tendon is weak. So patients that might exhibit this could be a woman who is pregnant, a patient who is overweight, or someone putting a lot of force at a time through their foot. So frequently a basketball player or a high impact player will exhibit stages of posterior tibial tendon dysfunction. So this is when a UCBL could be indicated because it can help neutralize the subtalar joint so that the talus, when it pushes into the navicular, it's in an optimal position where it's not, I guess, driving it as hard. Then it's also the arch in a UCBL. The material is rigid enough to support the medial longitudinal arch in order to prevent that arch from dropping too low. Okay, so you'll learn more about posterior tibial tendon disorder, but a really easy way to check for it is the heel rise test. So you want your patient to be able to stand on their tiptoes and just have their hands resting on the gate bars. But if a patient is able to raise themselves up on the balls of their feet or on their metatarsal heads without any pain, then their posterior tibial tendon is intact, and that's not the source of the problem. So I believe with Dylan, he has, sorry Dylan, I'm talking about your foot, but you can see that his navicular drops lower whenever he is ambulating, but Dylan is able to provide, or Dylan is able to stand on his tiptoes, perfectly capable of doing that by himself. He can do it with just one foot, or he can do it with both of his feet. Standing. Either way, Dylan can perform a heel rise test. He can stand on his toes. So, does Dylan have posterior tibial tendon disorder or dysfunction? No. But his navicular does drop a little bit lower when he's walking. So, is Dylan indicated for a UCBL? No, he doesn't need one, even though his navicular drops. So, that's a little bit confusing. You guys will learn more about posterior tib dysfunction. However, if the patient fails that test. So if the patient is unable to do a heel rise test, then they might be indicated for a UCBL to help support that arch. Okay. All right. What else do I have? Here we go. Flexible pes planus foot. So a pes planus foot essentially means that the foot is in a flat position, and pes planus or pes cavus is a condition that looks at the foot statically. So it's not a motion. It's a presentation of how a foot looks. So flexible pes planus. Now, a UCBL can be indicated for a flexible pes planus, but just because you have a flexible pes planus doesn't necessarily mean that you need to have a UCBL. What does that mean? One of my classmates right now, he has a very, very flat foot, but you don't see him wearing a UCBL. His foot is flexible, it can bend, but that doesn't mean I need to put him in a UCBL. So a flexible pes planus is not necessarily a thing that needs to be treated, right? If we look at children, children have flat feet through a lot of their childhood until usually 6 to 7 years old, I believe, is the age when we start to see a slight arch develop. But just because we don't see an arch doesn't mean that that person is indicated for any type of orthotic intervention. Could it potentially help them? Yes, but this would only be necessary if there were other pathologies or pain involved, and something that a foot orthoses with just a little bit higher medial trim line couldn't accommodate for, couldn't fix. So we would only want to have a UCBL if there was something else going on with a patient with a flexible pes planus foot. All right, another one is OA, osteoarthritis of the midfoot. So with osteoarthritis, we want to prohibit those bones from moving on each other because they're going to be really, really painful. So, when you were wearing those UCBLs, it was supporting your arch and your midfoot, and it's really trying to minimize the movement in that. So if we have a UCBL that contains and controls our hindfoot, it's also, in a sense, controlling our midfoot and not allowing those bones to rub very painfully between each other. Okay. And then one you guys have already talked about is a healing calcaneus fracture. And this is where we do those modifications that we keep talking about, which squeezes that fat pad to be a more tolerable weight-bearing surface. Right? And then the last one is metatarsus adductus. This kind of sounds like a Harry Potter spell to me, in all honesty. But it's when your metatarsals begin moving towards the midline. You can do, if you look at the UCBL, Kelly pretty much made one for me that would fix this without knowing it. But if you leave the medial portion of your UCBL longer, then that's going to prevent the metatarsals from moving more medially, or vice versa. If you leave a longer lateral side, you're going to prevent them from moving, from abducting away. So you'll go into these pathologies a little bit more, but understand that these are going to be indications or pathologies that you would consider using a UCBL to help compensate for, or this might be something that you would consider to deal with, to use. All right, so we've been talking a lot with UCBLs again about controlling the hindfoot and a calcaneus that is inverting or everting, blah blah blah. So we're going to go through some quick terms: pes planus, pes cavus, pronation, and supination. All right, so quickly, pes planus, pes cavus again is both of those are a presentation of how a foot can look. We want to, in this picture right here, it says a normal arch. Just remember, we kind of want to avoid using the word normal, because if a patient is not quote-unquote normal, this creates a negative psychological impact on the patient, because they can look at themselves now as abnormal, ostracized, or weird, however they want to view themselves, compared to everyone else. So we typically prefer to use the term typical. So typically, the population presents with this shape to the arch. However, that's not always the case. In this static presentation of the foot, it looks primarily at the medial longitudinal arch. Basically, a lower medial longitudinal arch presents as a pes planus foot, right down here, and then a higher medial longitudinal arch presents as a pes cavus foot. So typically you'll see, not always the case again, but typically a pes planus foot is going to be a little bit more flexible, and a pes cavus foot is going to be a little bit more rigid in the available range of motion. All right. Now we are going to look closely at pronation and supination more. You'll see these in your biomechanics and orthotics classes talked about, but this is just going to be a brief introduction. So pronation and supination, it's important to remember that they are dynamic movements, not static. And then these movements occur in all three planes. So if someone says, I have a pronated foot, or I don't even know what they would say, but pronation is a movement, okay? And so is supination. Pes cavus and pes planus are how they present. So, kind of like, but they're very similar in their mechanism. So if you think of pes planus, you can almost think of that as a snapshot or someone taking a picture of a foot going through pronation. And likewise, pes cavus is a still or static shot of a foot going through supination, almost in how they present. So pes cavus and pes planus are not moving. Pronation and supination are moving actions, right? So again, there are triplanar motions that pronation and supination do, and they have three movements associated. So here they go. So pronation is going to be created by dorsiflexing your ankle. So go ahead and do that while I talk through these. So pronation is going to be ankle dorsiflexion, forefoot abduction, so taking your metatarsals and your phalanges away, and then everting your calcaneus, okay? So this is going to put your foot in, or your ankle in a position of valgum. So that ankle is going to come more towards the midline, okay? So ankle dorsiflexion, your forefoot is kicked out, and your calcaneus is everted, which is making your medial malleoli come closer to your midline, all right? And so supination is going to be the exact opposite of pronation. So our ankle is going to be plantar flex, our toes are going to be pointed down. Our forefoot is going to be adducted or brought towards the midline, and our calcaneus is going to be inverted. So when you look at the calcaneus, when we talk about inversion and eversion, we're looking at the plantar surface of the calcaneus, not where the calcaneus is articulating with the talus. So we're looking at the very bottom of the calcaneus, and is it going in or out? So in supination, it's coming in, so it's inverting towards the midline on the plantar surface. Now the top of the calcaneus is going more laterally, but when we're talking about inversion or eversion of the calcaneus, we are looking at the bottom plantar surface of the calcaneus. Is it coming in or out? Okay, so just try to think about what is the very bottom doing, and that'll let you know your inversion or eversion, right? So again, pronation is made up of movement in all three planes. So we have, our dorsiflexion. So dorsiflexion is happening in our sagittal plane. We're going to have eversion right here. So this is what I'm talking about with the whole, let's see if I can draw. Alright, so like our calcaneus is right here, right? And we're kind of this shape. This is a really bad calcaneus, right? But you can see that our calcaneus is more angled this way, right? So this portion of our calcaneus is more kicked, wow, this is supposed to be an asterisk, but it's more kicked out to the lateral side of the foot, so it is going to be more everted or away from the midline, right? And then we are also going to have abduction of our forefoot. So right here with our forefoot, let's change the color, it's so cool. Right, with our forefoot, it is going to be abducted. So one of the tests that you guys will do eventually is called, I think it's called like too many toes or something. But if you have a foot that is presents with pes planus, or when you watch someone walk, if they have excessive pronation, you will be able to see toes on the lateral aspect of the foot. That's because the toes are being abducted away from the midline. This motion is occurring in the horizontal plane, so if you look down from an aerial view, that's where you would see these toes are coming away from the midline right here. Alright, so in the too many toes test, I believe more than 1.5 toes is an indication that we're having excessive pronation, or we are having a collapse of our medial longitudinal arch, or a few other things. Alright, so keep in mind this too many toes test that we'll be talking about. Okay. Alright, so let's go to the next slide. Alright, so supination. So you see we don't have, oh no, come back. Alright, so we don't have our too many toes anymore. And yeah, okay, so let's look. So with supination, again, we are going to have plantar flexion. So the foot is going to, toes are going to be closer to the ground. We are going to have adduction of the forefoot. So this part of the forefoot is going towards the medial side. And then our calcaneus is going to be inverting. So here's our calcaneus. Here's going to be the bottom part. So the top part is going more laterally. But this bottom part is going to be more on the inside, or it's going to be inverted. Okay. Alright, so got that? So the three things, this slide back here, are what you need to know definitely as definitions, or knowing how these present are crucially important. You will have to list these. I can almost guarantee that for you for quite a while. So definitely get to know these. I'm going to draw a big heart on them so you know them. Gosh, that's a terrible heart. Okay, anyway, so be sure you guys just have these in mind. You'll be taught them in your orthotic class, but I think these are really crucial to know when you're watching people walk and watching the foot. And it's good to get a little introduction to it before you actually get started. So XO, XO, pronation, supination. Alright, let's keep going. Okay, range of motion values. So we've talked about plantar flexion and dorsiflexion before and what's needed for both of those. So when we look at plantar flexion, just as a reminder, our passive, we get about 50 degrees. So remember I did this as a quiz question from last week. So with passive range of motion, you can point your toes down on average. Typically people can point them down between 45 and 50 degrees. We're going to go with 50 degrees, right? But I'm going to talk about gait range of motion. So GROM is not a real word or whatever, but I'm using it just for now. So let's do magenta. What color is magenta? Oh, that's cool. Okay. So this is the necessary range of motion for a more fluid gait pattern. All right. So we only actually need about roughly 20 degrees of plantar flexion to be able to walk. So when in the gait cycle would we have the most plantar flexion, do you believe? Okay, a lot of our plantar flexion is going to occur when we are in stance phase. We have already progressed over the tibia, and now we are going from terminal stance to pre-swing. So in that pre-swing, whatever, I'm not going to write it out. So in pre-swing, we are preparing to push our foot off. Our foot has gone through the windlass mechanism, and it is about to use this mechanism as a spring to propel the limb forward. So right now it is a rigid structure because that foot is going to be plantar flexed. Our great toe is going to be extended so that we can have that push off. But anyway, you'll learn more about that in biomechanics. Dr. Childers will do a much better job of explaining that to you. But definitely know these range of motion values. So for gait, we need 20 degrees of plantar flexion. right? So when we look at dorsiflexion, again, we talk passively. We can bring our toes to our nose, right, by about 20 degrees passively. But for gait, what do we need? So these are important values as well for you guys, okay? So we are going to need 10 degrees for stance phase. So what do you mean? Why am I really dorsiflexing my foot in stance? Yes. Yes, you are. So when you think about, when you have initial contact, um, your foot is definitely going to be dorsiflexed then, right? Because if your toes are down completely on the floor, you're going to drag them and you're going to trip and fall, right? So we need at initial contact to have that dorsiflexion to allow us to be able to pretty much brace to impact the ground, right? So we have dorsiflexion and a little bit of knee flexion so that when we have initial contact, it's not just completely jolting to our system, okay? So that's one time in the gait cycle that we have dorsiflexion. Again, we also have dorsiflexion during swing phase. So we need a little bit, this is pretty much for ground clearance, right? 5 degrees to pick up the toe just a little bit so that we clear the ground, right? So again, Dr. Childress will teach you a lot more about this, but know these values. So for plantar flexion, we have 20 degrees. Then for dorsiflexion, we have to have 10 degrees, and we have to have 5 degrees for these phases, okay? So whenever you get into more complex orthoses that require additional changing to trim lines and how much motion you give your patients, you have to make sure that, if possible, you want to provide them with um, the available range of motion that will help them have a fluid gait pattern. Because if we completely lock out how much they're able to dorsiflex or plantar flex, then this is going to change its gait pattern. It can produce pain in certain areas, but oftentimes we do want to resist plantar flexion from happening. So say if we have someone that has a drop foot, we don't want to let them plantar flex, right? Because they're just going to drag that toe. So they might have a few other difficulties, or if we block plantar flexion completely, they might have some trouble with the gait cycle, but they're not going to trip and fall as often. They're not going to be a hazard to themselves. So just keep these range of motion values in mind because you'll go through them in a lot more detail